Thank you very much. So we will continue, and I will share with you some of the techniques and tips to improve the healing environment for meniscus repair, because it is not very easy. We all know that meniscus and the microvasculature is a challenge. Most of these lesions that we encounter in the clinical practice will not heal if we don't do anything because of the lack of vascular supply, which is only present in the peripheral part of the meniscus. So these are the classic indications, and this is what we all should be doing in repairing meniscus both on the medial and lateral side. We're talking about these peripheral tears based or oriented in the vascular part of that meniscus. But if you look at the outcome of how good we are in doing surgery in this area, this is the data. This is very important data showing you that in the early days after meniscus surgery, we do see a number of reoperations in our meniscus surgery versus partial meniscectomy, which has less operations. And this is a downer if you would look at this data and analyze it very basically. However, if you have all the long-term data of meniscus repair, every singular study will show you that meniscus repair offers a benefit for your patient in the long term. All of these patients will do better if you had a repair done that was done successfully versus a meniscectomy. So this is the challenge, and this is why we're still here debating meniscus repair and other solutions for treating meniscectomized patients. We now also are aware that there's a number of indications where we actually are pushing boundaries of meniscus repair, because these are all very detrimental lesions to the meniscus and to the joint. We're talking about roots. We all know that root is a very concerning injury, especially for the athlete. We have meniscocapsular lesions. We have radial tears, where you actually lose the total function of the meniscus, and so we should be able to repair them at least in a number of these patients. And then you have these degenerative tears in the early or younger patients. And so all of these need attention and need advanced tools to actually make the outcome of this type of surgery better. So based on the current outcome and the introduction of these advanced indications, we need technology for augmented repair. That's the actual goal. The most important thing to get augmented repair is, to my idea, is actually have your brain augmented to the situation that you will have to do something, you will have to book a little bit more OR time, be relaxed, and have the tools available in your OR. The only way to be successful is to actually be prepared for success. And so this is one of my basic rules for augmented repair, is you need to augment your brain to be actually prepared to repair that knee. So this is what we should be doing in all of these repairs. It's not just sticking the fast fix in the back of the knee and saying, well, I've done a good repair. You need to actually prepare the lesion, diamond rasping, shaving, needling, Stedman picks. This is basic technology that all of you in the audience should actually be doing before you sticking in the needle and repair that meniscus. So this is just to increase the vasculature in that area and therefore increase the healing potential. We should also be doing microfracturing the notch, because those marrow elements are there, they're easily accessible. You take a microfracture hole, you puncture a couple of holes easily in front of the ACL. So you have those marrow elements and those stem cells in that environment, and you hope for the best. There is some technology on radiofrequency which has shown that by treating some of these lesions, you can actually have an increased repair potential and have a better outcome. The fibrin clot, and then we're moving into augmented repair. Charlie already showed you that this is very old technology, but we still keep struggling with getting that clot, which is very cheap to produce, but getting the clot into the area is actually very hard, and we're still struggling to make that happen in the easy repairable lesions, and especially also in the less easily repairable lesions. As you can see here, this is a horizontal tear, which is an advanced indication for meniscus repair, but especially in the young, I think this is worthwhile doing. The data on fibrin clot is very positive, and then surprisingly the data on PRP is less positive. It's a little bit more in between. It's similar, however, to fibrin clot, and you would anticipate by adding growth factors in there that the outcome would be better. It's still a rather expensive technology, still hard to deliver inside the lesion, and the outcome is variable. And I think most of the reasons is that we as surgeons become more critical in looking at and evaluating our outcome. Therefore, the outcome is a little bit more variable. But this is still a very easy and accessible technique for a number of these lesions. Meniscus wrapping is then really pushing the boundaries, and Thomas Piontek really is trying to convince us all that by adding bone marrow, adding and wrapping these complex lesions, we might actually be more successful. It's too early to tell at this point, but this is still, I think, a very promising technique. And then there's an explosion in stem cells, and the first clinical data shows the potential of this type of approach, especially in the white-on-white areas where we are actually not able to introduce any healing except if you add cells. And so these cells might extend the outcome and improve the outcome results in this very challenging indication. The conclusion is that meniscectomy is a potential kiss of death to the knee. We're still not 100% sure how healing comes about in the human being, and we should never forget the basic rules of engagement, which is prepare yourself and the patient, prepare the meniscus, rasp it, shave it, needle it, microfracture it, 4 things that you should always do. And then also you need to accept in some of these patients that we will end up with a failure, but then you end up with a simple meniscectomy, and I think that is actually saving. That is a very positive story. Advanced techniques are being developed, and the central theme of today is, of course, save the meniscus. Thank you very much.